Welcome back to the deep dive. If you're aiming to be a mental health professional or, just really curious about the mind, understanding how we think and learn is fundamental. Today, we're doing a deep dive into some really core challenges in psychopathology conditions affecting cognitive and intellectual functioning.
Yeah, that's right.
We've got some great material here on cognitive, communication, and motor problems,
Yeah.
but to really give you that deep dive feel, we're focusing on two big areas. First, intellectual and learning difficulties, the kinds that often show up early.
Uh-huh.
And second, cognitive decline, things like delirium and dementia, which we usually associate more with later life. Our mission really is to unpack these complex issues, go beyond just the definitions, and look at the real-world impact, the scientific debates, all the stuff that shapes clinical practice.
Exactly. We'll walk you through how these conditions are defined and understood, not just diagnostically, but from a really human angle too.
Yeah.
What's fascinating, I think, is how our understanding has shifted over time, sometimes dramatically. So it's crucial to keep multiple perspectives in mind. Get ready for some key insights into how these conditions actually play out and how we approach them.
Okay, let's kick things off with intellectual and learning difficulties. These are really foundational categories for understanding development. To make this concrete, let's look at two people. First, there's Yolanda. She's 22, has Down syndrome, an IQ around 48. Her parents are worried, about her future, especially her ability to live independently.
Right.
Then there's Alfred. He's 10, average IQ, but really struggles with reading, gets teased, acts out sometimes at school. But interestingly, he's captain of his football team.
Yeah, those two cases really set the stage nicely because they highlight the distinction between two key diagnoses. First up is intellectual development disorder, or IDD.
Sure.
It's defined by significant deficits in, well, two main areas. One is intellectual functioning, think IQ below 70, which is roughly 2 standard deviations below the average of 100. And the other is adaptive functioning. These are those everyday practical skills, communication, social skills, living independently, that kind of thing.
Right, the day-to-day stuff.
Exactly. And IDD isn't just one thing. There are different levels of severity: mild, moderate, severe, profound. The key thing to grasp is what these levels mean for daily life. Someone with mild or maybe moderate IDD, like Yolanda, might learn to live pretty independently, maybe with some support for complex things. But as severity goes up, the need for help with even basic tasks increases. Oh, and historically, the term used to be mental retardation, but we've moved to intellectual disability, or IDD, to get rid of those negative, harmful connotations.
That's important context. So Yolanda, with her IQ of 48 and those challenges with independence, seems to fit that moderate IDD picture.
Precisely. Then you have specific learning disorder, or SLD. This is what we'd consider for individuals, often kids, who have real difficulty with specific academic skills, reading, writing, math, and they're performing way below what you'd expect for their age.
Okay, so this is Alfred's situation.
Exactly. And the critical difference from IDD, which Alfred's case illustrates perfectly, is that SLD does not involve those broad deficits in overall intellectual and adaptive functioning. Alfred has an average IQ. His struggle is specific.
Right. We often hear about subtypes, don't we? Like dyslexia for reading problems, the difficulty decoding words, or dyscalculia for math, trouble with numbers and calculations.
Yep, those are the main ones: impairment in reading, writing, or mathematics. And it's also worth noting, these learning disorders often occur alongside other things like ADHD or autism. It highlights how interconnected these neurodevelopmental profiles can be.
So that naturally leads to the question, how do we actually identify these learning differences accurately? This has been a pretty big debate in the field, hasn't it?
Oh, definitely. A really interesting, sometimes quite heated debate. Historically, back in the late 70s and for a while after, the main approach was the IQ achievement discrepancy model.
Right, I remember learning about that.
Yeah, you basically compared a child's IQ score, seen as their sort of potential, to their actual scores on achievement tests in reading or math. If there was a big gap, a discrepancy, the thinking was, well, that suggests a learning disorder.
Makes sense on the surface.
It does, but the big criticism was that it was a wait-to-fail model. A kid often had to struggle, sometimes for years, and fall significantly behind before that gap was big enough to qualify for help.
Yeah, that doesn't seem ideal, waiting for them to fail.
Not at all. So an alternative gained traction, especially from the mid-2000s onwards: the response to intervention, or RPI model. The whole idea here is much earlier identification and support, using tiers.
Tiers, how does that work?
Think of it like this. Tier 1 is just good quality, whole class instruction. If students aren't making progress, they move to Tier 2, maybe small group help, more targeted instruction. If they still struggle, they move to Tier 3, which involves intensive individualized support and a more thorough assessment to figure out what's going on, potentially ruling out things like IDD. It's about intervening early.
Okay, that sounds much more proactive, catching kids earlier.
It aims to be. But like the discrepancy model, RTI has its critics too. Some argue that by moving away from the IQ comparison, it risks, blurring the lines between a specific learning issue and just general academic difficulty or even mild intellectual disability.
I see. The concern being it might over-identify SLD.
That's the worry for some, yeah. That it might label kids with SLD who are just struggling academically for other reasons. It really shows how these different frameworks shape who gets diagnosed and what support they receive. It's not just academic, it's got real practical consequences.
And speaking of definitions and consequences, we need to touch on a much darker part of this history. The way intellectual disabilities were viewed in the past. Well, it wasn't always about support.
No, definitely not.
The early 20th century eugenics movement. It's chilling. This belief that intelligence and other traits were purely inherited and that society should, prevent people deemed unfit from having children.
It led to horrific practices like forced involuntary sterilization in many countries, including the U.S. It's a really stark reminder of the potential harm that can be done even by people in helping professions when they operate under flawed, unethical ideas.
Absolutely. It really grounds us in why ethical considerations are so fundamental in everything we do.
Definitely. Now, if we link this back to biology, what do we know about the underlying causes? Genetics certainly play a big part in many of these conditions. For IDD, you have genetic illnesses like PKU, phenylketonuria.
PKU?
Yeah, it's where the body can't break down a specific amino acid. If it's not caught at birth and managed with a special diet, it causes brain damage. Then you have chromosomal abnormalities like Down syndrome, that extra copy of chromosome 21, like in Yolanda's case, or Fragile X syndrome linked to a gene mutation, more common in boys.
So genetics are key, but not the whole story.
Not at all. Problems during pregnancy, like the mother using drugs or getting certain infections, complications during birth, like lack of oxygen, or even childhood illnesses like meningitis or brain injuries, they can all contribute to IDD.
Okay. And what about learning disorders like dyslexia? Is there a biological basis there too?
Yes, definitely. Dyslexia is known to be highly heritable. It runs in families. Research points to specific genes being involved and also differences in brain activity, particularly less activation in areas linked to language processing, like the temporoparietal and occipitotemporal regions.
Interesting.
But here's where that shift in perspective comes in. Again, the neurodiversity idea. It asks, are these brain differences really disorders that need fixing? Or are they just natural variations in how human brains are wired, maybe even with their own unique strengths?
That's a really powerful reframing, moving away from a purely deficit-based view.
Exactly. It challenges us to think critically about labels and how we approach support. Does the focus always have to be on fixing the difference, or can it be about adapting the environment and leveraging strengths?
That leads perfectly into interventions. Beyond understanding the why, what actually helps. For IDD, what psychological approaches are common?
Well, applied behavior analysis, or ABA, is often used, especially with kids, to teach specific skills or manage challenging behaviors. It's very structured. This often goes hand in hand with cognitive skills training, which breaks down complex daily tasks like getting dressed or catching a bus or managing money into smaller, learnable steps.
Like with Yolanda. You mentioned she had this kind of training.
Right. She benefited from both ABA and skills training growing up, learning those essential daily living skills step by step.
For learning disorders like dyslexia, what works there?
Interventions are usually very targeted. They focus heavily on building foundational reading skills and, crucially, phonological awareness. That's the ability to hear and manipulate the sounds within words. It's fundamental for decoding.
Okay.
And here's a fascinating little side note. Music education. There's some intriguing research suggesting that training in music, especially focusing on rhythm, might actually boost phonological awareness.
Really? How does that work?
The idea is that processing rhythm and processing the sound structure of language might share some underlying neural pathways. So improving rhythmic skills could potentially transfer over and help with the phonological skills needed for reading. It's still being researched, but it's a cool example of thinking outside the box.
That is interesting. Shows how different brain functions are connected. But these individual interventions don't happen in a vacuum, right?
Okay.
What about the bigger picture social and cultural factors?
Absolutely crucial. Take IDD. There's a strong link with socioeconomic inequality. Poverty increases the risk. Think less access to good nutrition, healthcare, more exposure to environmental toxins. And then, having IDD can make it harder to get education and well-paying jobs, potentially perpetuating poverty. You mentioned Yolanda's parents facing financial struggles with her care costs. That's a very real aspect.
And for adults with IDD who can't live fully independently,
Group homes are a common residential option. The aim is to provide necessary support but within a community setting, fostering as much independence and social integration as possible. Quality of care is obviously key here.
and for learning disorders, is there a similar sociocultural angle?
There is, particularly from a social constructionist perspective. This viewpoint argues that how we define learning disorders is heavily influenced by our culture and specifically our educational system's demands, meaning that what counts as a disorder might look different in a different cultural or educational context. This perspective also pushes us to ask why learning disorders seem more prevalent in certain groups, like racial or ethnic minorities, or boys. Is it purely biological, or are there social factors, biases in assessment, or systemic issues in education at play? It reframes it partly as a social justice issue.
That's a really important critical lens to apply. Okay, let's shift gears now to the other end of the lifespan, thinking about cognitive challenges in later life. Delirium and dementia, these are huge issues impacting so many families. We have the case of Sanjay, 74 years old. Started with mild forgetfulness, but it progressed. Disorientation, trouble with daily tasks, eventually not recognizing his own grandkids.
Yeah, Sanjay's story is sadly quite common, and it helps us differentiate between two key conditions. First, there's delirium. This is more about a disturbance in attention and awareness. People might seem confused, have memory issues, but the key things are its rapid onset hours or days and its fluctuating severity.
Okay, so it comes on quickly and can change day to day.
Exactly. And crucially, delirium usually has a direct physiological cause, a medical condition like a UTI, a severe infection, maybe substance use or withdrawal. If you treat the underlying cause, the delirium often resolves. It's typically acute and temporary.
Got it. So different from dementia.
Very different. Dementia involves a permanent and typically progressive decline in cognitive function due to some underlying brain disease or injury. Now, the terminology has shifted a bit. The DSM mostly uses the umbrella term neurocognitive disorder, or NCD.
NCD.
Right. And it's broken down into mild neurocognitive disorder, where there's a noticeable decline, but the person can still function independently, maybe with extra effort or accommodations.
Okay.
And major neurocognitive disorder, where the decline is severe enough to interfere with independence in daily activities. Sanjay's progression clearly moved into that major NCD category.
Then these NCDs become much more common with age, right?
Dramatically so.
Yeah.
Maybe 1–2% of 65-year-olds, but that jumps to potentially 30% or even more by age 85. This prevalence leads to a really important debate. Is diagnosing mild NCD just pathologizing normal aging? Or is it a valid clinical entity that helps us identify people who need support or might benefit from early intervention?
Yeah, that's a tricky line to draw. Defining where normal aging ends and mild disorder begins.
It really is. And the history of understanding this goes way back. Ancient Egyptians, Greek physicians, they described states resembling delirium and dementia. But the real breakthrough for Alzheimer's disease, the most common form of dementia, came in the early 20th century.
It was Alzheimer's.
Exactly. He was a German physician who documented the case of a patient named Auguste Tutur. She had this severe progressive decline, confusion, memory loss, disorientation, just couldn't function. There's a heartbreaking quote from her medical notes where, when asked about herself, she says, "I have, so to speak, lost myself."
Wow, that really captures the experience.
It does. And after she died, Alzheimer examined her brain. That's when he identified the two key microscopic abnormalities that are now the hallmarks of the disease. Senile plaques, which are these sticky clumps of beta-amyloid protein outside the neurons, and neurofibrillary tangles, which are twisted fibers of tau protein inside the neurons. Finding these plaques and tangles is revolutionary, but, it's also worth noting that focusing solely on the brain pathology sometimes overshadowed Auguste Tutur's actual lived experience, a reminder to always keep the person central.
Absolutely. So, biologically, what's the thinking now? How do those plaques and tangles cause dementia?
The leading theory, often called the amyloid hypothesis, suggests that the buildup of amyloid plaques is the critical starting point. These plaques somehow trigger problems with the tau protein, leading it to form tangles inside neurons. This whole process disrupts communication between brain cells and eventually leads to cell death and brain shrinkage, causing the cognitive decline.
But the exact link is still being worked out.
Yeah, the precise relationship between plaques, tangles, and symptoms is still incredibly complex and actively researched. Genetics definitely play a role, too. There's early onset Alzheimer's, which hits before age 65. It's rarer, but often strongly genetic, linked to specific genes like APP, PSEN1, PSEN2.
And late onset.
Late onset Alzheimer's after 65 is more common, and the genetics are more complex. The APOE gene, particularly the APOE4 variant, increases risk, but it's not deterministic. Environmental and lifestyle factors play a huge role. This brings in the cognitive reserve hypothesis.
Cognitive reserve.
The idea that things like higher education, mentally stimulating jobs, or engaging hobbies might build up a kind of brain resilience, a reserve. This doesn't prevent the plaques and tangles from forming, necessarily, but it might allow the brain to cope better and function normally for longer despite the underlying pathology.
So keeping your brain active could genuinely help.
The evidence suggests it can, yeah. It supports the idea that it's not all predetermined by biology. Which leads us to treatment. What can we actually do?
Is there a cure yet?
Unfortunately, no cure for Alzheimer's yet, but there's progress. Some newer drugs, given intravenously, actually target and try to clear those amyloid plaques. Lecanemab is one showing its promise, though an earlier one, aducanumab, had pretty mixed results and a lot of controversy. Then there are older drugs. Some work on the cholinergic hypothesis, basically boosting the neurotransmitter acetylcholine, which is involved in memory. Drugs like Dunpezil, which Sanjay took. Another drug, memantine, works on a different neurotransmitter, glutamate.
Do they stop the disease?
No, they don't stop it, unfortunately. They might slow the progression of symptoms for some people for a limited time, and they all come with potential side effects. It often becomes a difficult calculation for families, like with Sanjay, who was later given antipsychotics for agitation, balancing the potential benefit against the risks.
A very tough situation. So medication is part of the picture, but not the whole solution. What about psychological approaches?
Right. Cognitive enhancement therapies are a big area. The underlying idea is that staying mentally active and engaged can help slow the decline or maximize remaining function. This includes things like cognitive stimulation activities, memory training, or rehabilitation focused on specific daily tasks, maybe using memory aids, playing word games, practicing routines.
Did Sanjay try any of this?
Yes, early on, he participated in some cognitive interventions like working with pictures and practicing memory tasks, and they seemed to help temporarily, boosted his functioning for a while, but sadly the disease eventually progressed beyond what those could manage.
So cognitive engagement helps, but it's not a cure-all.
What else? Physical activity is strongly encouraged, both for prevention and potentially slowing decline. And then there's the relational side. Person-centered care is crucial, creating a supportive, nurturing environment that respects the individual's dignity, focuses on their remaining abilities, and helps manage things like depression or agitation.
Focusing on the person, not just the disease.
Exactly. And for individuals who become very withdrawn or difficult to connect with, there's an approach called pre-therapy. It's a very structured, person-centered way of trying to make emotional contact, offering empathy and validation, even when verbal communication is limited. It's about maintaining that human connection.
That sounds incredibly important for quality of life.
Yeah, it really is. And this brings us back to the sociocultural context. How does society shape the experience of dementia? Well, social factors matter hugely. Things like social connection, education, leisure activities seem protective. Loneliness, on the other hand, increases risk. Even midlife hearing loss, if it leads to isolation, can be a risk factor. These are things we can potentially modify.
Interesting. What about other factors?
Gender is a significant factor. Women have a higher risk of developing Alzheimer's, partly because they live longer, but potentially also due to factors related to gender inequality impacting cognitive reserve over a lifetime. And women are disproportionately the caregivers. About 2/3 of dementia caregivers are women, facing huge burdens. Lower socioeconomic status and chronic stress are also linked to higher dementia risk.
And the care systems themselves.
They play a massive role. Daycare programs can be invaluable, providing stimulation for the person with dementia and, critically, respite for caregivers. Sanjay attended one, which gave his wife, Marcia, a much-needed break. Eventually, long-term care options like nursing homes or assisted living often become necessary, though they're expensive and access isn't always equitable. Marcia ultimately had to make that tough decision for Sanjay.
Right.
And finally, culture shapes how we view dementia. Some argue that Western industrialized societies tend to over-medicalize aging and heavily stigmatize cognitive decline, sometimes seeing it as a kind of living death.
Whereas other cultures might see it differently.
Potentially, yes. Some Native American or Hispanic Latino cultural perspectives might view aging and cognitive changes differently, perhaps as a natural part of life cycle, a connection to ancestors, or a time deserving special respect. The point is, we need to move away from stigma towards promoting active citizenship and dignity. With dementia affecting 55 million people globally, and that number growing fast, the WHO's push for dementia-friendly communities is absolutely vital.
Wow. We've covered so much ground. From understanding the nuances between IDD and SLD with Yolanda and Alfred, to the devastating progression of dementia in Sanjay's case, and the historical context like eugenics and Augusta Turing. It's clear how biology, psychology, and culture all weave together.
It's been a real deep dive, hasn't it? We've seen the debates around diagnosing learning disorders, the vital importance of ethical history, the impact of stigma, and how social factors profoundly shape conditions like dementia. It really highlights the need for a holistic view.
Absolutely. So for all of you listening, especially those heading into mental health fields, the big takeaway is really the importance of seeing the whole picture. It's never just the diagnosis. It's the person, their history, their environment, their culture. As you continue learning, maybe think about one thing from our discussion today that you'll look at a bit differently now.
Yeah, we really hope this conversation gives you insights that go beyond the textbook, things that will stick with you and inform how you think about these issues, and ultimately, how you provide care with more understanding and empathy.
Couldn't have said it better myself. Thank you so much for joining us on this exploration. Keep asking questions, stay curious, and we'll catch you on the next deep dive.